Good day, dear great surgeon. Hope you are doing great. You already have been doing great with such great topic like pathology. So let's continue our pathology session. We were talking about the hypersensitivity and you have been doing great. And yes, tuberculosis is type 4 hypersensitivity, as you all told us. Let's reshare the question to make it appear. So yes, it's type 4. And the Graves' disease is type 5. And type 4, it will appear just within minutes after exposure. Type 4 hypersensitivity will appear minutes after exposure immediately. So immediately, it will be type 1. But type 4 will be the second exposure later on, delayed. Delayed, exactly. So if we have, for example, an autoimmune hemolytic anemia, like the gut bacterias, it will be which type of hypersensitivity? How about serum sickness? How about a graft versus host disease? How about asthma or fever, hay fever or asthma? So the asthma or hay fever is type 1. It will be just minutes after exposure. But the type 2, it's example for the cytotoxic with the IgG and the IgM. It's a surface antigen. And the example will be autoimmune hemolytic anemia, while type 3 is the serum sickness and aspergillosis. And it will be a response within hours. And it's example for the immune complex. While type 4, it's a delayed type, and the mediator will be the T cell, and very common to be noted with the delayed action of the tuberculosis and graft versus host disease. Keep this in mind. So let's have another question. It will be about the core of the pathology. So be ready. Are you ready? Which of the following is false? If you have an old man with ulcerated lesion in his right cheek and it got excised, histological assessment give us that it's a squamous cell carcinoma. What is the statement that is false regarding the squamous cell carcinoma?
Precisional biopsy.
Again, he is telling you that the radiotherapy will be not safe for squamous cell carcinoma. In fact, it might be needed. The man have a squamous cell carcinoma, and it has a significant risk of metastasis. Rare, but rare doesn't mean it can't occur. And although cryotherapy has been used for squamous cell carcinoma, but surgery is the mainstay. So, radiotherapy is safe treatment for squamous cell carcinoma and might be used in such cases. But it's unwise to use radiotherapy in areas bruised to radionecrosis, like the nose. And the poor prognostic factor for the squamous cell carcinoma, if it's deeper than 4 millimeter or the size more than 20 millimeters, it will have a local recurrence up to 15%. How about what is the difference between the squamous cell carcinoma and the basal cell carcinoma? Main word. Invasion. So the basal cell carcinoma is locally malignant, but the squamous cell carcinoma is malignant. Squamous cell carcinoma is the second most common skin malignancy, while the basal cell carcinoma is the most common skin malignancy. How about the melanoma? Is it more common or the squamous cell carcinoma? Melanoma or squamous cell carcinoma? Which is more common? So in order of incidence, we have the basal cell carcinoma, then the squamous cell carcinoma, then the melanoma. Thank God. And if you want to diagnose squamous cell carcinoma and basal cell carcinoma, the basal cell carcinoma will be indurated or not. Let's have this funny diagram. I like it. It's collecting the main differences between the basal cell carcinoma and the squamous cell carcinoma. And in real life, this will be a guide to show you. A photo can save you a lot of memorization. This is my school. This is what I believe in. And I encourage all of you to search for an illustration for every idea you face. Clear? What is the rodent ulcer? Basal cell carcinoma. Why are you so silent regarding the difference between the basal cell and squamous cell? I want to hear from you. Which one of them will be raised beaded edge? Raised beaded edge is basal cell carcinoma. Is there an imaginary line that can be drawn in the face that can tell you the most probable places for basal cell carcinoma? It's from where to where? It will denote the basal cell or the squamous cell.
Basal cell.
Above it, the basal cell, or below it?
Above basal cell.
And below it?
Squamous.
In the lips, it's more common to be basal cell or squamous cell?
basal cell,
In the lips?
squamous,
So yeah.
or
How
basal,
about the ear? How about the ear? Squamous cell or basal?
basal cell carcinoma,
How about the eyelid?
dermoid,
basal cell,
So the basal cell is the most common cell cancer in the eyelid, while in the ear, the most common skin cancer will be the squamous cell carcinoma. Those incidents are very important to be noted because medicine is important incidents. It's all about the incidents. Clear? The
yes,
basal cell or
clear,
the squamous cell will be palisading in order under histology, histopathology. Which of them will be palisading? The basal cell carcinoma will be palisading. Yes, the basal cell carcinoma will be the palisading. It will be basaloid epithelium. Clear? Wow. It's a very important topic, by the way, to
clear,
differentiate between the basal cell and the squamous cell carcinoma. It's in every chapter, in every subspecialty, whatever your specialty is. Either if you are otorhinology or general surgeon or plastic surgeon, you have to be familiar with those topics. This is what is meant by being palisade. Clear?
clear,
yes,
Let's have a happy question for you to give you some fresh air. You like all about the breast. Breast is the best. So we have an old woman, an old lady with a bloody nipple discharge on mammography. There is a calcification behind the nipple areola complex, and a core biopsy show a background benign change, but the cells that show a comedo necrosis, but doesn't breach the basement membrane. What is the most likely? Comedo necrosis is a feature of a high nuclear grade of adductal carcinoma in situ, and it have a high risk of being associated with invasion.
Paget disease,
That's great. You answered all correctly. Yes, it's adductal carcinoma in situ. Let's have another happy question. Or I stress on, would you like some question on the breast cancer? Or you are not ready? I feel I will be too mean and will be evil if I ask it, which will do a prophylactic mastectomy. The ductal carcinoma in situ or the lobular carcinoma in situ? I said I will be mean. Dr. Aisha got the idea. So the lobular carcinoma is very famous to be bilateral, but we don't do prophylactic mastectomy for the lobular carcinoma inside. We do for the ductal carcinoma inside. Even though the lobular carcinoma is more common to be in both breasts, bilateral, while the ductal carcinoma is not bilateral. The lobular carcinoma in situ is not surgically excised prophylactic. This is the trick. This is the idea I want to stress on. Clear?
Yes.
You agree with me or you want to make sure? If anyone in doubt, you can search for it. So let's have another question. So we agree that the ductal carcinoma in situ will require mastectomy or excision. When to do mastectomy or when to do wide local excision for the ductal carcinoma in situ? Don't be shy to talk out. So we will do mastectomy for ductal carcinoma in situ if it's more than 4 centimeters. But if it's less than 4 centimeters, you can do just wide local excision and prepare this patient for mammoplasty. Clear? Hope this is clear. And in every situation, you have to discuss with this lady the reconstruction option for her. And if you are going to do a radiation for the patient, would you go for a silicone implant as an option or not? If you are planning for radiation for this patient, if you have a breast cancer and have a patient that require radiation after surgery, would you ask her and discuss with her the reconstruction? Would you recommend a free flap like DIAP or TRAM, or you will give her an option like silicone implant if she is requiring radiation? This question is not tricky one. It's all about wound healing. Radiation impairs wound healing and will cause extrusion of the implant and the silicone implant and extrusion of any foreign body. So yes, Dr. Naim, yes, it will be the flap. It will be the best choice for reconstruction. Thank you. So let's move on and have another happy question. Ready? Let's have another happy question about burn. See, this is pathology. Pathology is revision of every chapter. Which of the following doesn't occur as a pathological response to extensive burn? In extensive burn, there will be hemolysis due to damage of erythrocytes by heat and microangiopathy. There will be a loss of capillary membrane integrity, causing plasma leakage into interstitial space. And that's why there will be no use if you give this patient a blood in the very first hours or even the very first day, unlike a major trauma In major trauma, it's now advised by the ATLS protocol to give blood from the very first minutes, especially in hypovolemia or suspected blood loss. But in extensive burn, he will not have any use for blood. It's all about evaporation of the fluid. He required fluid resuscitation guided by the urine output and extravasation of the fluid from the burn site causing the hypovolemic shock. If you give him fluids, you already have blood. He requires only fluids. And that's why you will find there is increased hematocrit, but decrease the blood volume. This is a trick. And of course, keep in mind, there will be risk of curling ulcer. And as well, you might have a dilatation in the gastric balloon. He will have a dilated stomach. So this is due to a dilated stomach will be due to paralytic ileus. The term paralytic ileus is not confined to the ileum. It's all about the gut. There will be a paralysis due to the extensive burn shock and the hypovolemia and loss of the fluids. Yes, it's due to electrolyte imbalance. So in this question, what doesn't occur? Thank you, Dr. Bartholomew. There will be no absolute polycythemia, but there will be hemolysis as a response to extensive burn, and there will be plasma leakage in the interstitial space. There will be increased hematocrit, but decreased blood volume. This is the extensive burn. And the best idea and the best way to follow up a burn patient resuscitation will be guided by.
Urine output.
Thank you, Dr. Ibad. You still great as usual. It's all guided by the urine output. And the formula for burn will be named Parkland formula. Any one of you know the Parkland formula for electric burn and the difference between the adult and the children? In electric burn, it will be 4 milligram per kilogram per kg in electric burn, while in adult will be 2. In pediatric will be 3. This is the ATLS protocol. Keep it in mind, and in every exam you will have an equation. It will be an easy one, but keep it in mind. And it's following the ATLS protocol 10th edition. And if he didn't ask you about the equation, he will ask you about the follow-up. The monitor for you will be the urine output. Hope this makes. So, an extensive burn, the very first day, would you recommend giving blood transfusion? Blood transfusion for extensive burn? So I have been talking to myself.
No.
Thank you, Dr. Aisha. You saved the whole day. There is no blood transfusion in extensive burn in the very first day. He has a hemo concentration. Why you give him blood? Give him resuscitation. Let's move on for this. I have a question for you. We have an old lady screening mammogram, and in here we have 58-year-old lady. How would you do screening for her? Ultrasound or mammography? Wake up.
Mammography.
Mammography. Thank you, Dr. Ibad. And yes, If it's below 30-year-old, how would you investigate for her?
Ultrasound.
Ultrasound.
How would you screen for a lady below 30-year-old with a family history?
MRI.
MRI. That's great. So let's get back to this question. We have a 50-year-old lady screened with mammogram and the presence with suspicious ductal carcinoma in situ. And the ductal carcinoma in situ require excision, or you just follow up like the lobular carcinoma in situ. The carcinoma will be
Excision.
excision. Great. If it's more than 4 centimeter, require mastectomy or wide local excision.
Mastectomy.
If it's below 4 centimeter,
Wide excision.
that's great. So the presence of invasion is a hallmark of invasive disease. And that's why there is no feature for ductal carcinoma inside. The presence of invasion is a hallmark for a cancer, not ductal carcinoma in situ. The cutoff between the in situ and the true cancer is the invasion. Clear? So in this patient, you will find nuclear pleomorphism and coarse chromatin, abnormal mitosis, even angiogenesis. But infiltration of the suspensory ligament, this will be not carcinoma in situ, this will be true cancer. And take care, the whole trick is that angiogenesis, yes, it might occur with high grade of ductal carcinoma in situ. So ductal carcinoma in situ is not a cancer, but it's a precancerous. And even though it will be treated surgically. Clear? Okay. Let's have another question. Or you need a rest? I feel you have been exhausted today.
Continuous.
Okay. I won't be harsh on you and will give you few more questions and meet again later on. We will have an old man presenting with a purple region in his forearm, excised, and it's a 3 centimeter Merkel cell tumor. Which of the following statement related to this diagnosis is false? We all know that Merkel cell tumors are cutaneous tumors, consists of sheets and nodules of hyperchromatic epithelial cells with high rate of mitosis and autosis. And they're relatively easy to distinguish from biogenic granuloma, which has no features of malignancy. Biogenic granuloma that bleeds on touch has no features of malignancy and will not show any lymphovascular invasion. What is not true? D or B or C or what?
P.
Again, look at the question. He is asking you what is false, not what is right. In Merkel cell tumor, you will find lymphovascular invasion. So this is true. It's not false. Yes, he will require sentinel lymph node biopsy. Yes, histologically, it is not resembling biogenic granuloma. If you can't differentiate between the Merkel cell and the biogenic granuloma under microscope, how can you diagnose it? So yes, this is the false one. Histologically, they are not resembled. So D is the difference. Clear? The whole trick, you don't know about the Merkel, that it's associated with visceral metastasis or not. So yes, from this question, you now know the idea that the Merkel cell is a skin tumor that comes in the forearm, yet it can have a visceral metastasis. Clear? So it's a rare but aggressive tumor. It's derived from the intradermal epidermal Merkel cell and usually present in the elder one, like this patient. He's already a 69-year-old man. He is very old. And the pre-orbital area is the commonest site. So it's related to sun damaged skin. And histologically, it will be the key to differentiate it from the biogenic granuloma, even though they are clinically differentiated. There will be a lymphovascular anastomosis and a lymphovascular invasion. So you have to keep this in mind. And there will be a visceral metastasis. But your key in the Merkel cell will be the histopathology. That's why learn from your juniority, learn from your juniorhood in surgery to send every excision, every excised cell or tissue to histopathology. This is your key. And how would you treat a Merkel cell? It will be treated with a surgical excision, and your margin will be 1 centimeter. How about the melanoma? The melanoma, the melanocytes are derived from which type of cells? Sudden question. Melanocyte is derived from which embryological origin?
Neural crest.
Neural crest.
Neural
Thank you,
crest.
Dr. Sahar. From the neural crest. The melanin, the melanoma, is a benign or malignant melanoma?
Malignant.
Malignant. So it's an oma, but malignant. How about a giant hairy cell tumor? Giant hairy cell tumor melanoma. Giant hairy cell melanoma. It's malignant or not?
Malignant.
It's not malignant. It might be pre-malignant. Exactly. The melanoma has two classifications regarding its aggressiveness. Who know it? It's all about the depths. Who can remember it? The depths of the melanoma. Clark?
This is by Breslow thickness.
Breslow? Breslow and what else? We have two classifications for the depths. Clark and Breslow. So the deeper is the better?
No, deeper is worse.
Thank you, thank you. So happy to hear from all of you. So you have been all tired, so let's have a happy ending question. It's about an ice cream. If you remember ice cream in surgery, you have two things to think about: the phaeochromocytoma VMA and what? Imbun and the Sufi. Yes, Sufi will love you. So What is untrue regarding the pheochromocytoma? The pheochromocytoma has a rule of tens, 10% bilateral, 10% in children, 10% malignant, 10% hypertensive. I don't like the 10 rule. I like the 90 rule in this because the majority will be unilateral. The majority will be adult. Thank God it's not in children. And the majority is not malignant. So thank God it's a good sign. And the majority will be hypertensive, unfortunately. That's why I don't like the rule of tens. The only deceiving thing will be the hypertension because the majority will be hypertensive. So the pheochromocytoma will be hypertensive or not?
Yes, hypertensive.
So
Hypertensive.
in our question, which will be untrue?
Option E, 40% hypertension.
So it's up to 90% will be hypertensive. It's not 40. So this question, by all means, number E is wrong because we have either it's 10% or 90%. There is no 40% in the pheochromocytoma. If you don't know the percentage or any idea about the pheochromocytoma, you have to remember that it has a 10% or 90%. The rule, the majority about the 10%, which is very famous, but I want to register the 90 rules for me regarding the pheochromocytoma. Clear? The BMA for pheochromocytoma is in blood or urine?
VMA in
Urine.
urine.
In urine. How about the blood? What you investigate for the pheochromocytoma in blood?
Metanephrine.
Yeah.
Thank you. Thank you. That's correct. The metanephrine. The pheochromocytoma is associated with which syndrome? Men type 1 or men type 2?
Men type 2.
Men type 2A or type 2B?
2A. 2B also have pheochromocytoma.
How about the hyperparathyroidism? Which syndrome type?
Min 1.
Men 1? How about men 2
1 and 2A.
and 2A? So you have been doing great. So happy to have been with you. I hope this happy question made you happy by the end of this session today. Until we